All right, let's dive right into this explainer. Today, we're unpacking exactly how first responders and medical systems somehow managed to bring order to the unimaginable chaos of a mass casualty burn disaster. I know, it's a pretty heavy topic, a grim reality for sure, but preparing for the absolute worst is literally the only way to save lives when a catastrophe strikes. We'll be looking at the foundational frameworks and protocols straight from the Advanced Burn Life Support Guidelines. We're going to see exactly how medical pros shift gears from everyday routine care into a highly structured, full-blown disaster response mode. So, here's our mission briefing to break all this down. We're going to cover the anatomy of a burn disaster, bringing order to chaos, the math of survival, the critical first steps, and finally, the invisible radiation threat. Okay, part 1. Anatomy of a burn disaster, defining the scale of crisis. To really wrap our heads around a burn mass casualty incident, we first have to grasp the sheer, overwhelming scale of these catastrophic events. It's not just about a bad fire. We're talking about an event that instantly, and I mean instantly, shatters the normal limits of our healthcare infrastructure. Just imagine a local hospital that's perfectly equipped to handle, say, 5 severe burns, suddenly receiving 50. What happens when resources are stretched completely past their breaking point? Well, history is unfortunately filled with tragic examples. Whether it's the 2001 terror attacks, the 2003 Rhode Island nightclub fire, or that 2015 Taiwan explosion that sent 500 injured people to 50 different hospitals, disaster always strikes where people congregate. The defining characteristic here is that the threat, or actual loss of life, completely exceeds what local resources can handle. Because burn injuries, they require a massive amount of personnel, specialized equipment, and a whole lot of time. When 500 people are injured all at once, the system literally has to adapt on the fly. Now, there is an absolutely critical difference between a hospital's standard daily capability and its absolute maximum crisis limit, which we call surge capacity. Capability is just what a burn center can comfortably handle on a random Tuesday, right? It fluctuates. But there is a hard metric to keep in mind. Surge capacity is exactly 1.5 times the number of available burn beds in a center. That's a hard ceiling. Once you cross that line, you are no longer operating under normal conditions. You are officially relying on regional or even federal disaster networks to step in. And that's exactly where the American Burn Association staging system comes into play. It's kind of like a tiered alarm system. In a Stage I disaster, local burn centers can still manage the situation. But if it escalates to Stage 2, well, now a regional network has to step in. And a Stage 3? That is a truly catastrophic event. That's when a unified command actually has to tap into federal assistance and pull from the strategic national stockpile just to get essentials like cadaver skin and wound care supplies. It's a massive, massive operation. So, moving from the medical side over to the logistical impact, the National Incident Management System, or NIMS, actually categorizes these disasters by what they destroy. Type 1 is the big one, the most devastating. It wipes out critical infrastructure, think highways, utilities, which makes the response incredibly difficult. We're talking massive earthquakes or improvised nuclear devices here. Then there's Type 2, which overwhelms the healthcare system itself, like a major explosion that produces hundreds of trauma and burn patients all at once. And Type 3 primarily impacts the specialized burn care system. Imagine an isolated nightclub fire where the injuries are mostly thermal. It might not destroy the roads, but there are still enough patients to completely exhaust those local burn beds. Which brings us to part 2, bringing order to chaos, scene safety and triage. Okay, so when first responders roll up to a horrific, totally unpredictable scene, you might think they just rush right in, right? Actually, their very first step in bringing order to all that chaos is stepping back. Responder well-being absolutely has to come first. Only after a strict risk assessment is done can the actual medical sorting even begin. I mean, disaster scenes are frantic, they seem completely out of control, but no one should ever put themselves in danger if there's little chance of actually improving the situation. Reckless acts, they don't make you a hero. They just degrade the entire rescue operation and put everybody else at risk. And that brings us to triage. It's a cold, hard, but ultimately life-saving logic that divides victims into 4 color-coded categories: red, yellow, green, and black. The goal here isn't your standard everyday emergency care. It's about maximizing overall survival when you have very limited resources. So red means they need immediate treatment to save a life or a limb. Yellow means their treatment can be temporarily delayed. Green is for the walking wounded, basically people who just need minimal care. And then there's black. And black represents the absolute hardest decisions in medicine.
This right here is the truly grim reality of a disaster. Care literally has to be withheld sometimes from those given a black tag so that those limited resources can be used to save the greatest number of people. Now, a black tag or expectant category doesn't necessarily mean the patient has passed away. What it means is that their prognosis is so poor that given the severe lack of resources, treating them would eat up the time and supplies needed to save maybe 3 or 4 other people who have a much, much better chance of pulling through. It is an incredibly heartbreaking, heavy burden for medical professionals. But in a mass casualty incident, it's an absolute necessity.
Let's look closer at that in part 3, the math of survival, calculating life and death. So once the tags are out, you've really got to wonder, how on earth do medics make those incredibly difficult choices objectively, especially in the field when people are in agonizing pain? How does a medic look at 2 severely burned individuals and instantly decide who gets loaded into the ambulance and who stays behind? It seems impossible, right? Well, responders actually cut through all that emotion by using 3 critical biological factors to do the math of survival. This math of survival relies on a direct intersection between a patient's age and the percentage of their total body surface area that's been burned. The survivability grid clearly lays this out. Patients falling into the green zones have a high probability of survival, so they get immediate priority. But for patients in the gray zone, it's a different story. If a patient is over 60 years old and has burns covering more than 50% of their body, they automatically fall into that expectant or black tag category. The math simply tells us that their chances of surviving the grueling recovery process are just too low to justify spending those scarce, immediate disaster resources. But it's not just about age and the size of the burn. The third factor is inhalation. If a patient has inhaled smoke or toxic gases, their survival chances absolutely plummet. Airway swelling dramatically worsens what is already a precarious situation, and it forces triage teams to instantly adjust their calculations. So, to recap, those 3 main pillars of burn survivability are the percentage of total body surface area burned, the patient's age, and whether or not they have an inhalation injury. Moving on to part 4, the critical first steps, the primary survey. Okay, so jumping into the definitive care phase. This is where responders follow a really fast-paced checklist, because the very first medical actions they take can literally mean the difference between stabilizing a patient or losing them entirely. It's the classic ABCDEs of trauma care, but adapted for burns. First, airway. They have to assess this immediately, because burn swelling can close an airway off in no time. Then breathing and ventilation. For circulation, they start massive IV fluids for anyone with burns over 20% of their body. Then disability, checking neurostatus, and exposure, keeping them warm. But here's a really notable point. Protocols instruct responders not to intubate expectant or black tag patients. Why? Because in a disaster, ventilators are like gold. Using a ventilator on a black tag patient could mean a red tag patient dies suffocating. And while all that's happening, pain management becomes this massive, massive logistical hurdle. Burn pain is excruciating. So to manage this reality across hundreds of patients, hospitals need enormous stockpiles of opioids and sedatives. Honestly, it's one of the quickest things to deplete a region's medical reserves. If IV supplies start running low, responders might have to fall back on oral or intramuscular narcotics, but the sheer aggregate volume of pain medication required in a mass casualty event, it's just staggering. Finally, part 5, the invisible radiation threat, dealing with dirty bombs. Now, we have to talk about the absolute most feared scenario in a mass casualty event, a disaster that combines thermal burns with a radioactive dirty bomb. What's absolutely crucial to understand here is the difference between mere exposure and actual contamination. See, external irradiation is just like getting an X-ray. There's no risk to others. But external contamination? That means radioactive material is physically on the person's skin or clothes. That patient is a continuous hazard to every single person around them. If they are brought into a hospital without being decontaminated first, they will instantly contaminate the ambulance, the emergency room, and the doctors trying to save them. So, to prevent the medical team from becoming victims themselves, immediate field decontamination is mandatory. The golden rule here is, do not become the next patient. Responders suited up in personal protective equipment have to strip off the victim's contaminated clothing, which actually often removes the bulk of the radioactive material anyway. Then they gently irrigate the skin with water, and you absolutely cannot submerge the patient in a tub because that would just spread the radioactive particles everywhere. Instead, you irrigate, let the water run off into contained areas, and repeatedly scan them with a Geiger-Müller counter until the readings are totally clear. Only after all that can normal trauma and burn care proceed safely. Ultimately, whether we're talking about a massive structure fire, an explosion, or a radiological event, the procedures we've explored today are the only things standing between a disaster and absolute systemic collapse. It all relies on cold math and strict protocols to do the most good for the most people. Which leaves us with one pretty vital question. If disaster strikes your city tomorrow, is your healthcare system truly ready to bring order to the chaos? Thanks so much for joining me in this explainer, and keep learning.